I am so excited by how much connection and community I'm seeing around these conversations here in the room. It's crazy. And online, we're all seeing all your comments coming through. So all of that's awesome. And I'm even more excited to be moderating for our keynote speaker today. I feel really blessed that he is willing to come and speak to us today from his really decades of experience in so many ways. And I'll tell you a little bit about him. Our keynote speaker today is Dr. John Molina. Dr. Molina is Pascua Yaqui and Yavapai Apache. He's the director of the Arizona Advisory Council on Indian Healthcare. Dr. Molina has held positions as compliance officer and health systems director for Native Health Urban Clinic, health systems director for the Kanaitsi Indian Tribe, thank you, chief executive officer for Phoenix Indian Medical Center, and assistant director and medical director for the Arizona Health Cost Containment System, ACCESS. He practiced as an OBGYN physician with the Indian Health Service and Las Fuentes Health Clinic, which he founded in his hometown of Guadalupe, Arizona. Dr. Molina is a graduate of University of Arizona College of Medicine and Arizona State University, Sandra Day O'Connor College of Law. Woo! He also received an honorary doctoral degree in letters from A.T. Still University of Health Sciences for his humanitarian work. Dr. Molina is faculty with the University of Arizona College of Public Health and ex officio board member with the San Carlos Apache Healthcare Corporation. His interests are in the alignment of Indigenous medicine and Western medicine and Indian healthcare law and policy. He is a U.S. Navy veteran. Dr. Molina enjoys participating in Indigenous cultural events with his wife, Dr. Stephanie Little Hawk Big Crow, Ogala Lakota from Wakapamni District in the Pine Ridge Indian Reservation, South Dakota. Together, they have 6 adult children and 11 grandchildren. Yeah, so he's got a little bit of a resume about that long. We are just so excited to have him here as our keynote speaker. And today, he's going to talk to us about how policy impacts maternal health in Indigenous communities. So I will turn the mic over to you.
Thank you, Camille, for the very kind introduction. I just greeted you in our Indigenous languages from my ancestors. But just let me say, first of all, that how privileged and honored I am to be here. You know, as I reach this, what we Indigenous countries look at as my last cycle in life, is that I'm very honored to have had all the experiences and all the mentors that I've had throughout my life. And indeed, the Creator has blessed me, I have to say, with not only good health, but an experience that I've come to enjoy and given back to our Indigenous communities. And even at this stage in life, I find that I can sit there and listen to all our panel speakers and still be able to gain insight and ideas in the work that you're so passionately doing. You know, the one thing I've always shared with people that I've worked with is, you know, you're never too young or never too old to continue to learn. And I really embrace the conversation that you've all had, what you've shared, because I know that the energy that I feel here is powerful. In our Indigenous way of looking at life, it's all about energies. And I think that this is something that we feel when we come into venues like this, being empowered, being encouraged, finding direction. And so I'm the one that's really honored to be here with you all today. So thank you. Thank you very much. I'll go on to our next slide. The thing I always begin with is education is not the kindling of a flame, is a kindling of a flame, but not the filling of a vessel. I always look at these sort of events as not only gaining knowledge and sharing knowledge, but out of these sessions, I always anticipate we're going to come up with some ideas some action plans, some things that inspire us, that we hear maybe in a different way that we didn't hear it before. And this really sort of drives a lot of work that we do in policy. And I think with regard to policy, it's one of the areas that got me very interested very early on in my career. After I finished my residency training, well, let me step back a little bit. My father is full-blooded Pascual-Yaqui. He was born and raised in the community of Guadalupe, where he passed away just a year ago before Christmas at the age of 91. And my mother is actually from San Carlos, but she's really from the Yavapai Apache bloodline. You know, during the Apache Wars, San Carlos was created as a military fort, and a lot of the indigenous people were rounded up and put in San Carlos, even the Yavapai Indians and the Hualapai Indians. A lot of the Indians were just brought together and put in San Carlos. And after the wars, a lot of our indigenous people went back to their homelands again, back to the Prescott Valleys, back to Fort McDowell, back to the Pima. So there was a lot of sort of changes that happened during that time, but my bloodline is actually Yavapai Apache from Fort McDowell. However, my mother was born and raised in San Carlos, and she actually was raised in a wickiup. Some of you know what a wickiup is, and so she lived out in the desert. And for this reason, she doesn't like go camping at all anytime. So that's her story. The next slide. So I just want to start out with some definitions. And of course, you know, this is one thing that I think drives in the work that we do, just to understand, you know, where we're at and to set the sort of a format. But policy is a deliberate system of guidelines to guide decisions that we're making, as well as to achieve outcomes. Now, it's very deliberate. And when I look at policy making, I always think about, let's start by looking at the outcome first. What do we want to achieve? And then begin to work backwards, because that's what drives your passion. That's what drives what you see in communities, is you want to see a certain outcome. So let's start with the outcome when developing policies, and then we start to work back. It's a statement of intent and is implemented as a procedure or protocol. This is what drives a lot of the work that you do, that I heard today, that you shared with us in the work that we do in communities. And then also it's adopted by governance body within government, business, and organization. So it's structured. You know, bottom line, policy is structure that guides us, but I always think that it's intentful. It's something that we want to do. It's driven not only by the outcome that we want, but the passion that drives you, the passion that drives me in the work that you're doing. So policy for me is something that's very, very much alive in the work that we do. Policies are important because they define what it is and what is not acceptable in reaching the desired outcomes. So this is a framework that we drive policy. And just to give a little story, is that the reason that I actually practiced OBGYN for just over 15 years at Phoenix Indian Medical Center. And then I had a practice in my community of Guadalupe. It was a small nonprofit practice. And during my career as an OBGYN, I'd say about 95% of my patients were indigenous, native indigenous patients and Mexican indigenous patients from across the border. And I have to tell you, it was the most wonderful career that I had in taking care of our patients. And the thing that drove me, though, that I realized that even as a provider, I enjoy taking care of patients one-to-one, sitting with them and sitting with our patients and sitting with the family and sitting with their partners and delivering babies. It was a beautiful experience. But what I came to realize is that there was a lot of challenges to a lot of our women that we talked about today, especially around benefits and access and coverage. And this really disturbed me, you know. And at that time, we were back in the early 2000s, Arizona was going through a referendum, Proposition 204, which was to raise the level of coverage for beneficiaries under Medicaid. So I became a very strong advocate for that. I worked with a group of attorneys and I went around the city as a physician, advocated to improve healthcare benefits for our Medicaid population, which turned out to be successful. Well, after it was over, one of my friend attorneys said, "John, you know, you really like policy, don't you? You really like." I said, "Yeah, because this is where everything happens up here. We enjoy taking care of people here, but decisions are made up there. This is where it really counts." So he says to me, well, John, maybe you should think about going to law school. That's something you might enjoy doing. So I thought about it, and sure enough, I think that's the next journey that I took, because then it allowed me to look at higher levels of decision-making, policies, things that you're involved in that drives the work that's going down at the front end. So with that, after OB/GYN career, I went ahead and took over a lot of and went into different areas of work, but always within the ITU system. The ITU system is an Indian Health Service system, which stands for I for Indian Health Service, T for Tribally Managed Programs, and U for Urban Indian Clinics. So my whole 30-year career has really been working within that system of care, whether it's a hospital, tribal organization, or urban Indian clinic, even as far north as Alaska. So I've been the one that have really learned quite a bit, and have really been very much pleased with the work that's happened in that area. Next slide we'll go to now. So this slide actually came up a little bit earlier, and I'm glad it came up, because this is what I think really drives a lot of the, kind of helps us see where the big pockets of issues and challenges are in looking at some of the factors that drive disparities in maternal health. And this was really well covered before. I really enjoyed this slide. But the thing that I want to also kind of bring out from this one is we look at the different social economic factors, and you kind of read down the line, what happens is that one line that says racism and discrimination. Racism and discrimination. Let me tell you, folks, in all the years that I've worked in this profession, I think nothing drives more barriers than racism and discrimination. It can be structural. It can be also very personal. And sometimes you don't have to be outward. These racism and discrimination doesn't have to be just outwardly apparent. It can be very subtle, very subtle. And our people feel that. You can feel it. And I think that's one of the reasons that I feel that drives a lot of women not wanting to go to their prenatal care practices, prenatal care, because of that practice. When I had my clinic in Guadalupe, Las Fuentes Health Clinic, it was just a joy to be able to take care of our moms and deliver their babies. And at that time, I was delivering babies at Banner and Tempe St. Luke's and here at St. Joe's. And most of my patients were from Mexico. They're a relative just south. And we made it very accessible to them by hours, parking, having physicians, having people there that spoke the language, that understood the culture. And these were very powerful driving factors. Speak the language, know the culture. Because this helps to establish a meaningful relationships that patients can trust, can feel comfortable, and they feel it. So we were very successful in being able to take care of our moms. In the practice that I had, I was in partnership with a family doctor and a nurse practitioner. We all three spoke Spanish and took care of them. And but then the political environment changed. And I think that's why it's so important to look at that other factor of the political environment. This was back in the middle 2000s when Sheriff Joe Arpaio, bless his heart, and I've talked with him, I know him very well, were doing the immigration sweeps. You remember that back in Mesa and Tempe, where anyone, including my father, got pulled over because of a rear tail light that didn't work, or maybe a license plate that was kind of falling off. They were pulled over. And this, of course, caused a chilling effect on women wanting to get out to get their prenatal care. They were afraid of getting picked up. And in fact, it got so bad that the sheriff's office, Maricopa County Sheriff's Department, that the town of Guadalupe contracts with, had their police cars parked at both entrances of Guadalupe, just parked. Don't you get a kind of an eerie feeling when you see a police car parked and you're driving by? You just kind of feel like, okay. But what do you think it feels like for some of our women who already feel there's racism and oppression going on? So that's why I think it's very important, and this is not a political speech, but to think about our country, and during this time, especially during elections, that's another social determinant of health that we have to consider, not only for healthcare in general, for our ethnic and people of color healthcare, but for women who are delivering our babies. The other one, I think, and again, this was really covered really well before. As you can see, these are all the factors, and I think a lot of you work in some of these different environments here, where you've experienced and you've seen some of the potential opportunities that you have to be able to drive policy to improve these factors. Next slide. Policies impacting maternal health. Well, this was also covered earlier. I'm glad you all covered this earlier because I can give my little stories and fill up the time a little bit. Access to healthcare services, absolutely. Being able to get to your clinic, policies can increase health services before, after pregnancy. And of course, Medicaid, as you saw some of the data on the Medicaid, how much women are covered on Medicaid. I've really enjoyed working in the state of Arizona because I think their Medicaid program is just amazing. They've really done a lot to improve the healthcare of our underserved people. They have great relationships with Indigenous communities. I've had that experience to work with them. And they're very much of an innovator. As you know, they were the first state to become a managed care organization. And this was quite a big change. Arizona was the first. And it's really provided a lot of benefits for people in Arizona. And I remember talking to the law professor that actually came up with the idea of a managed care state for Medicaid. And he wrote a paper that was called the Building a Better Mousetrap. And it kicked off the Medicaid managed care program here in Arizona, just to go to show how innovation can drive policy. And, you know, sometimes we feel we're up against a brick wall and we can't do anything. But it's these sort of environments that gives us ideas on how we can sort of manage and go around things as we share our stories, share our ideas, and share information and share data. Data, of course, drives policy. But I think the bigger motivator, the bigger thing that drives policy along with data is you, your passion, your interest, and the love with what you do. Coverage and benefits, again, that's the other one that was talked about earlier. And I think one of the things we want to do is continue to look for opportunities where benefit coverage can be improved for people. As you heard just recently, CMS, the Centers for Medicare and Medicaid, approved the Access 1115 waiver to reimburse for traditional services. So that's a big win. That's a big win. And now we have a traditional healing work group that I work with Access and my team to begin to operationalize how this is going to work regarding the coding, the billing, and everything else. And the other thing that's going to happen during this next legislative session coming up in 2025 is to introduce bills, because now the legislature has to sort of approve and give their blessings and a budget to be able to drive this home. But it's been a work that's been going on for almost 10 years. So that just shows the resilience of people like yourself who continue the work. We don't give up. We keep moving. We keep kind of moving ahead to try to find and look for those opportunities to improve healthcare. Policies impacting maternal health is support systems. And obviously we have some great people here and yourselves that spoke a lot about some of these systems that are in place, from education to empowerment to community focus groups. The other thing that I think is important in the work that we do is health literacy. Health literacy is so important for women. Some of the work that we do with the Arizona Advisory Council on Indian Health is we put together summits and conference on health literacy as a way for people to get empowered, to understand, a lot of this health kind of information and data and things that would help them make their own decisions regarding their health. And of course, data collection. This is always something that we're always involved in. I appreciate the work at ADHS and the University of Arizona and the programs that they have to collect data. Unfortunately, the thing that I find with data collection in Indigenous communities, it's very difficult to get to. They're siloed, there's pockets. Being able to get the right data that you need, or being able to get the right identifiers that you need. This has always been a challenge. And I think that's something that's gonna, I see as an improvement going forward. I know that Contexture, which oversees the health information exchange here in Arizona, is gonna be working with Indigenous tribes to try to sort of get an arm around how we can get data, health data, that helps support a lot of the work that we're doing, and a lot of the information that's going to like ADHS and other types of government agencies. Next slide. Social determinants of health. We talked about that: housing insecurity and food insecurity and nutrition. These, and I think for me, when I look at the social determinants of health, again, I mentioned, uh, discrimination, racism. Housing is another big issue among our people. We just completed a grant with Arizona Department of Health Services called the AZ-HIP. And what just was blaring out of that whole grant was this challenge of housing. Now, housing is getting expensive, even for us. It's getting expensive. But think about folks that are trying to just make a living, especially in the urban areas, rent and trying to find places. Among a lot of our underserved patients, Indigenous people, we find, multiple generations living under one roof. Very common in tribal communities, where we have, the mom, the grandma, and the child living under one roof and trying to make ends meet. And that, of course, you can already sort of predict the type of social determinants of health that will impact out of that. Poverty is a big one. Among Indigenous communities, it can be as high as 40 to 70, 80% poverty levels, especially with my wife's community in South Dakota, Pine Ridge, unemployment rates of almost 80%. So again, housing, poverty, and education is the other one. A lot of our young people are dropping out early, and they're very difficult to find jobs. So I think for me, a lot of the main drivers in improving healthcare outcomes is education, housing, poverty. Those are things that I think, and of course, racial discrimination. So all these factors are sort of play into each other. That's why it's so good to have all our folks together here to be able to begin to share some of his ideas and thoughts. Next slide. Indigenous healthcare. Again, I think one of the things that we find with healthcare in Indigenous community is in Indian Health Service, very much underfunded. It only provides about 40% of the budget needed to run a lot of these facilities. The other part is made up by third-party revenues like Medicare, Medicaid, private insurance, geographic barriers that we saw, historical trauma and mistrust. I'm glad that was brought up. That is still a continuing thing. We need to heal from these episodes. It's intergenerational. We continue to feel the impact of intergenerational trauma, historical trauma. Cultural competency is something that's being moved a lot. It was interesting to see that slide where Florida, had their thing with cultural competency, but disapproved cultural health equity. But the other part of cultural competency, one step higher, is cultural humility. That's a whole different area now that's being researched in terms of how people can begin to be able to reflect on different cultures and have a better understanding of where they sit in terms of that culture. And then finally, Medicaid expansion. That's one thing that we continue to do here, especially for different pockets of people. Again, the Medicaid program here, I think, is an amazing program here in Arizona that really helps support a lot of that movement. Next slide. Positive impacts, increase Indian Health Service. Again, we need more funding for Indian Health Service. Tribes are always at the time for budget allocation, trying to improve healthcare funding for Indian Health Service. Community-based programs, which have found to be very effective. The work that you're doing in the community, right at the grassroots. Cultural competency training, cultural humility training, again, to improve understanding of Native American culture and health beliefs was brought up really well. And tribal sovereignty, empowering tribes to make decisions for themselves. Tribes stand in a very interesting position here in the US where they're considered sovereign nations. They're considered sovereign nations because guess what? When the government when Europeans first came in to colonize this country, they established treaties with certain tribes. The very fact that they established treaties showed that they recognized they were sovereign. Treaties are only made between sovereign nations, and they established these treaties. Constitutional law followed, legislative law, which shows that Indian people, communities have a sovereign status in their ability to negotiate with state and federal government. Next slide. Love this one, sacredness of pregnancy. All my years of delivering babies, hundreds of babies, I really came, not only in the delivery part of it, but in my indigenous way of thinking that pregnancy is sacred. Pregnancy isn't just not a medical condition. It's a sacred spiritual condition. A life is being created, a life, which even now scientists and medical doctors don't totally understand. When I was trained at Maricopa Medical Center, which that old building is soon to come down, unfortunately, there's a lot of great memories there. I was actually born at Maricopa County Hospital. But at that time, it used to be located on 35th Avenue in Durango, and then it got moved over here. But anyway, while I was there, I work closely with midwives and nurses. They have such a caring heart. They really do. And I really connected to my patients. I really did, because I really felt it was such an honor to deliver an infant, an honor, especially the mom, the dad, the people there. And unfortunately, the residents that I worked with thought that was too much, and they call me Bleeding Heart Molina. So, but that's only because I recognize the sacredness of pregnancy, the delivery, that infant. That picture on the left shows a safety pin on the garb of a lady, and a lot of my Hispanic women from Mexico wore safety pins. Does anybody know why these safety pins were worn? Has anybody seen them? Oh my goodness. Yeah, they would stick it on their underwear at the top, or they would put it on like this. And when I did some research on that, from what I understand, and I took from it, was that in the old Aztec indigenous ways, when women were pregnant, they would do a ceremony and they would put a sword or a knife over their belly as a way to protect the infant from bad energies. So now that's carried on still by putting up a safety pin. The garb their indigenous wear is important in protecting the pregnancy, not only from the physicalness of the world, but also from energies around them. That right there is me with our granddaughter, cradle boards. That's from South Dakota. Very important not only to protect the infant, but the beating is significant. There's meaning to the beating and the symbols to protect that infant. Next slide. This just shows a coming of age ceremony, sunrise dance, sunrise Apache, my relatives, to show that even in a young age, the young women coming of age, the mothers, grandmothers talk to her about pregnancy and motherhood. Next slide. And this just shows that we want to go from health disparities to health equity, where every person has the opportunity to attain his or her full potential. But let's take it one step further. Next slide. This just shows the equality and equity, how the difference is. Equality was a big thing back in the 60s, but it just showed it didn't work. We then transferred to equity. Let's make things a little bit different for people to get to see the ball game. But maybe let's take it a little bit further. Next slide. Health justice. Take down the barriers. And a lot of this not only involves the work we do around policy, but law and legislation, things that we need to change structure in our country to improve healthcare. Next slide. I can hear some stomachs growling, so I'm going fast here. I'm just kidding. See, I have hearing aids, so I can hear really good. This just shows some of the impact on maternal health care during the pandemic. There were changes in health practices, more severe disease coming out because of access to care, anxiety, depression that came out. Remember, a lot of it was difficult to get to, social distancing, quarantining, and just down the line, You can see how a pandemic can solely impact that. So, in a lot of the tribal communities, we're getting ready for the next pandemic. Not that there's going to be one, but we just need to be prepared on how we're going to learn from this for potentially a next one. Next slide. The equitable healthcare system. Well, for me, it's a system of care with integrated services. And we've talked about that here, behavioral health services and other services to help in the pregnancy journey, meaningful access to care, identifying risk early, levels of care that they can access that are appropriate, comprehensiveness of care, training in social determinants of health, cultural awareness, competency, and promote efficient use of resources. Next slide. Okay, so I'm going to stop here. And this is something that comes from Chief Sitzerimbo. He says, let us put our minds together to see what we can build for our children. And that's a photo of our granddaughter, my granddaughter, when she was just almost 3 years old at one of the powwows in Albuquerque. But the one thing that I have, just to close this conversation, my personal experience in the delivery of Indigenous women and their infants was not only the sacredness of the pregnancies, but the understanding that we're giving our children their identity. We're giving them an identity. Because Indigenous resilience is all about keeping our sovereign status, our culture, our language. And where does it begin? Right there. Teaching our kids. That's why it's so important that we take care of mom and the family, because it's about the next generations that are coming forward, And this young girl, my wife made her regalia, very traditional, teaching her Lakota words, teaching her Lakota language. She's now 5 years old, getting ready to go into Lakota immersion. That's what we're doing. That's what you're doing for Indigenous women. Not just about the women and family, but this is what it's all about. This is where it's at. And just to finish my last story, I got to name her. I wasn't prepared to name her, but after she was born, my wife turns to me and she goes, in Lakota tradition, the grandfather now has to name the baby. Now, I'm not going to say all Indigenous people do this, but Indigenous ways, you kind of wait till the baby comes, then you figure out what the name's going to be. Of course, one can, in the Western way, you try to figure a name of the baby and look at baby books and baby names and think of something. But in Indigenous way, sometimes you wait until that baby's born because you want to see what the energy of the world is like in order to name that baby, right? So when my wife looked at me and told me, well, now, Grandpa, you got to name the baby. I've never named a baby. But I kind of knew what I had to do. So it was October the 5th in Rapid City, South Dakota at the hospital. And we're like on the 3rd floor. And I was looking out the window and it was kind of much like this kind of a day. It's quiet, sunny, very mild, calm. But they were expecting a blizzard come that 3 days coming up. And we're expecting a blizzard. So in my way of thinking, I thought, well, gee, why don't we name her the calm before the storm? The calm before the storm. So that was my way of thinking. My wife thought it was great. The mom thought it was great. The calm before the storm. Now we went to our elders in Lakota to translate that into Lakota, because technically a lot of our Indigenous people, youth, don't have English names. They have Indigenous names. So we got that translated, and translated the calm before the storm into Lakota is Iwoblu Ikatoba Amblekle Awia. Try to put that on a birth certificate. That's the other thing. What about women who want to name their babies doesn't fit the format of a birth certificate? That's something we can change, because we want to get back to empowering women. Because what I found in delivering babies, when women felt, Indigenous women felt that they were respected, validated, and allowed to do their ceremonies that really increase their well-being, that really enhance a sense of well-being, that would address such issues, anxiety and depression, because now they were empowered by their very own culture. Much like when I was at Phoenix Indian Medical Center, after a baby was delivered, the mom, once a baby, was delivered from nursery to the mom, she would get the first meconium and smear it on her forehead. My child is here. That's how sacred pregnancy. And I think we're missing that in Western culture. It's too sterile. When I was in residency, Dr. Molina, there's another baby, Dr. another baby. It's just so sterile. We miss that. And I think our indigenous people want to embrace that sacredness again, to feel it. And I think when our providers, our hospitals, and the system do that, I think we're going to make a real big difference in maternal health care. So with that, I'll end. Thank you very much. I don't know if there's any questions at this point. Anybody has a comment or question?
Yeah. Wow, thank you. That was, I think tears came to my eyes about 5 times in your presentation. Thank you so much for that. That was beautiful. We have time for maybe 1 or 2 comments or questions. If anyone would like to say anything or has a question.
Thank you.
Yeah.
You're welcome. Thank you.
Yeah. Yeah. Wow. Yeah. Just wow. Thank you so much for giving our keynote today. I feel very rooted and grounded in the work that we're doing and the importance. And I'm just so grateful that you exist. Yeah. So let's give him another round of applause. Yes. All right. So as Dr. Molina pointed out, your stomachs may be growling. We do have a delicious lunch planned. They are setting up and actually are probably completely ready at this point. Yes, in the back. So in the back room, you can find a delicious lunch. During lunch, we want to make sure you network, connect with each other, and visit our sponsors. We may also need a little help at the end of lunch transitioning this large room into 2 smaller rooms because we have 2 breakouts going on in the afternoon. And so if you take a look at your Whova app, you can decide which one you want to attend after lunch. There are also, again, wonderful prizes if you're on Whova, and you can put photos on there as well. So those of you who are taking photos during the session, feel free to post them. And then we also have our raffle that is continuing to go on. And if you want to buy raffle tickets, they're up at the front. Everything supports 4th trimester. And with that, I will see you back at 1:30. This room will be the Magic Formula Science, Data, and Networks. And no, sorry, this room will be Systems Change in Healthcare. And in the breakout room back there will be the Magic Formula Science, Data, and Networks. Thank you so much.